Dear colleagues, I'm Filippo, Crea, Editor-in-Chief of the European Heart Journal. Welcome to the second EHJ Dialogue. I remind you that we will have a dialogue every week with leaders in cardiovascular medicine from the 5 continents. The dialogues are Socratic conversations among editors, authors, and readers. They are free and they are live streamed. Please ask questions and we will answer. And please like the newly created YouTube channel, subscribe to it, and press the bell to be notified of new content. And now it is my great privilege to ask Professor Linde, who is executive editor of the European Heart Journal, to start the second dialogue with Professor Packer. Cecilia, please.
Hello, thank you, Filippo. Hello and welcome, everyone. I'm Cecilia Linde. I'm a professor of cardiology at Karolinska Institutet in Stockholm, Sweden. And it is my great privilege to present Professor Packer to you. Professor Packer is also a long friend of mine. Professor Milton Packer is currently Distinguished Scholar in Cardiovascular Science at Baylor University Medical Center in Dallas. He is an internationally recognized clinical investigator who has made seminal contributions to the field of heart failure, both in understanding its mechanisms and defining its rational management. His work has spanned more than 40 years and has established a cornerstone of our current heart failure medication with such treatments as ACE inhibitors, beta blockers, angiotensin neprilysin inhibitors, and SLG2 inhibitors. But he was also instrumental in raising concerns about other treatments for heart failure patients, such as positive inotropic agents, calcium channel blockers, and antiarrhythmic drugs. For his achievements, he received the Lewis Katz Lifetime Achievement Award from Columbia University College of Physicians and Surgeons. Milton Packer has authored over 500 peer-reviewed publications and has been the principal investigator of more than 20 large-scale international randomized controlled trials in heart failure. Since 1986, he has been a primary consultant to the FDA on matters related to the design of clinical trials and the interpretation of clinical trial evidence. So who better than Milton to ask this question? You have witnessed the evolution of our understanding heart failure. From an historic point of view, what are the main steps in our knowledge of the mechanisms of heart failure?
Well, let me say, first of all, I'm so delighted to be here with you and Filippo, and this is such a great opportunity. This is a great forum. Developing these dialogues is just a wonderful mechanism and opportunity to talk to people and give them a history that otherwise perhaps they would never know. So let me just begin by saying thank you. Heart failure has an unbelievably interesting history. Many people may not know that heart failure is one of the oldest diseases known to mankind. There are reports of heart failure on Babylonian tablets from 5,500 years ago. And during almost the entire history of heart failure, physicians have not understood the disease. For the vast majority of the time, people thought of heart failure entirely as a fluid retention disorder. People would accumulate fluid, and that was heart failure. In the 17th century, the idea first emerged that heart failure was a disease of the kidneys because the kidneys retained water, the kidneys retained salt. So heart failure was a kidney problem. Well, that changed relatively recently. it was only in the 20th century when people began to realize that there was actually something wrong with the heart in people with heart failure. There were autopsy reports showing, well, the heart looked terrible, dilated, scarred, fibrotic. And then people realized, well, maybe there's something wrong with the heart. But of course, our only knowledge of cardiology during most of that time was as a hemodynamic disorder. We measured cardiac output and filling pressures, and that is what happened in the 1960s and 1970s when we had invasive hemodynamic monitoring, we had imaging techniques, and people all of a sudden said, oh my God, heart failure is a hemodynamic disease. It's not a kidney disease. It's a cardiac disease. Well, the problem was that it was a hemodynamic disease, but it wasn't clear that hemodynamics was the driving force behind heart failure. And we realized that there are hemodynamic abnormalities in heart failure, but if you make the hemodynamics better, you don't necessarily make heart failure better. And so in the early 1980s, mid 1980s, we moved from heart failure as a disorder of fluid retention to heart failure as a hemodynamic disorder, to heart failure as a neurohormonal disorder. And we recognized that many neurohormonal mechanisms are activated in heart failure. Maybe that wasn't so surprising. But what was important was the evidence that these neurohormonal factors actually drove the progression of heart failure. That was a very important shift in our thinking. So we have moved from heart failure as a fluid retention disorder, heart failure as a hemodynamic disorder, heart failure as a neurohormonal disorder, and now we're beginning to move into thinking about heart failure as a cellular disorder. And we can talk about that more, but we have really changed our thinking about heart failure enormously. But we are very patient. It's only taken us 5,000 years to get it right. So it's not a problem.
Well, that's a fantastic story. I mean, what happened with the neurohormonal hypothesis? Are you the father of that hypothesis? And how is it linked to the evolution of these drugs that are so crucial in heart failure management for hePF?
If I claim to be the father, I would have to wonder who's the mother. And I don't want to think about who the mother might be. So let me suggest that in 1992, I wrote a paper that proposed and described the neurohormonal hypothesis for the first time. But that paper synthesized the thoughts of many people at the time who were beginning to think along the same lines and shifting from a hemodynamic to a neurohormonal way of thinking. I may have used the concept in a paper for the first time, but in all honesty, there are many fathers and many mothers.
So wonderful. And then all successful stories such as yours many times are accompanied by some drawbacks and disappointments. Did you have any such experience in your success story concerning drugs that you investigated, for example?
Most of, I have many more failures than I have successes. So I have, Cecilia, I haven't counted.
No, I was thinking about the inotropic drug that you tested sometime.
The question, so that's such an interesting question. The question is, was the trial that you're referring to?
Yes.
It has such an interesting history. This was the PROMISE trial.
Yeah.
It was the first trial, big, large-scale randomized trial of a positive inotropic drug, milrinone, in people with heart failure. And before that trial began, I had already written for years that I thought that positive inotropic drugs were not useful and in fact would be dangerous in people with heart failure. And I wrote about it a great deal. It was very controversial. There were many people who really thought that positive inotropic therapy was a good thing. And there was a lot of disagreement. So it was perfect time to do a trial, a large-scale trial. What was amazing to me was that the sponsor of that trial asked me to be the principal investigator because I was not an advocate for positive inotropic drugs. I was actually saying, I am worried about these drugs. I think these drugs are going to hurt people. And yet they asked me to lead the trial. And I did. I had so many wonderful colleagues who helped so much. And the trial showed that positive inotropic drugs hurt people. And it was confirmed in many other trials. So, Cecilia, I wonder, was that trial a disappointment? Or was that trial the fulfillment of an expectation?
Well, maybe it was the fulfillment of an expectation, and just as you were saying before, it's the neurohormones that drive hePF. So maybe increasing contractility is not
Right.
positive unless in acute intensive care situation where it's only used temporarily.
But I think that there have been many examples of trials where I had hoped for a positive outcome and I was disappointed. And in fact, in all honesty, I've been disappointed many more times than I've been delighted. When you are a clinical investigator, the goal is to be happy once every 5 to 7 years. You cannot expect to be happy every year. You can't expect to be happy every 3 years. Every 5 to 7 years is actually, that's pretty good. I would be really delighted. But the people have sometimes asked me, what was the greatest disappointment? What trial was the trial that I really had hopes for? And I was saddened when I got the results. And that trial is a trial people don't talk about very much. It was a trial called Overture. It was a trial with omapatrolat. This was a drug that had a single molecule that inhibited ACE and neprilysin. And it was the first trial to ever test whether neprilysin inhibition would be useful for the treatment of heart failure. And we carried out the trial. The trial showed very unimpressive results. And we were so disappointed. We really thought that neprilysin inhibition would work. And then we recognized after the trial had been completed, based on a lot of research and discussions with the sponsor, that we had gotten the dose of the drug wrong. The drug was supposed to be given twice a day. We gave it once a day. We did a whole trial with a dosing regimen that did not cover 24 hours of neprilysin inhibition. And so after we recognized that, I said, we have to do neprilysin inhibitor trial again. We have to do it. We have to do it right. And for the next 10 years, I tried so hard to get any sponsor to do another neprilysin inhibitor trial. And sponsors kept on saying, no, no, no. You already had a chance to show that the concept would work, and you were disappointed. We are not going to make such an investment again. And then all of a sudden, we heard that there was a pharmaceutical company that was making a neprilysin inhibitor. And they were making it for the treatment of hypertension. And we said, what a great opportunity. We're going to run to the sponsor and we're going to convince them that, that developing a neprilysin inhibitor for hypertension is not a good idea. You have to develop a neprilysin inhibitor for heart failure. And we met with the sponsor. We made our strongest possible case, and we were given the opportunity to do it again. We did it again with the Paradigm HF trial. This is with sakubitil valsartan. And Cecilia, let me say one thing. One rarely gets the opportunity to have a second chance. Second chances in life are very, very rare. And so if you ask me what is my greatest disappointment, it was Overture. And I think my greatest degree of satisfaction and closure was when our theories about neprilysin inhibitor were confirmed in Paradigm. It was a once-in-a-lifetime opportunity to say, if you give me a second chance, I will get it right.
Well, that's wonderful, but it also tells you never to give in, and I'm sure you never do. So we move over to another subject I know, which is, what we are struggling with right now. It's the distinction between heart failure with reduced ejection fraction, which is what we've been talking about, into heart failure with preserved ejection fraction. So what about the distinction concerning both the diagnosis and treatment of these disorders?
So there's a wonderful story here. Remember, I can try to answer your question by telling you what's in the medical literature, but I would actually prefer to tell you a story. And so the difference between heart failure in a reduced ejection fraction and heart failure with a preserved ejection fraction is the measurement of ejection fraction. Everyone measures ejection fraction. Everyone thinks that measuring ejection fraction in cardiovascular disease is important. And everyone thinks that measuring ejection fraction in heart failure is particularly important. So here's the story. Let's ask the question, who ever came up with the idea of ejection fraction? Who invented ejection fraction? Well, if you look at the literature, the first paper ever to report on the measurement of ejection fraction was published in the 1960s. The first author was Stuart Bartle. Stuart Bartle was a research fellow in the University of Virginia. The University of Virginia had one of the first cardiac catheterization laboratories, and he developed the concept of ejection fraction. He actually referred to it initially as ejected fraction. That was the term he used in the paper. And he thought it was silly. He thought it was a silly idea. And but he published it, and all of a sudden, the whole cardiology community embraced the idea of ejection fraction. And Stuart Bartle was so upset that he left cardiology and developed a career in psychiatry. This is a true story. And he became a very famous psychiatrist in New York City. I met him and asked him about ejection fraction. And he explained to me that a cardiologist should never believe in ejection fraction, that ejection fraction is not a measure of systolic function. Ejection fraction is a measure of volume. Remember what ejection fraction is. It's just stroke volume over end diastolic volume.
But Milton, even though that may be the case, we're using it. And for the definition of hePF, the ejection fraction border has moved from 40, and now some of us are thinking that the border for hePF should actually be above 55%. So what happened to it?
Here's the problem. The problem is that we're reasonably comfortable that we know what's going on in people with an ejection fraction of less than 35. These patients have big hearts, they're big volumes, they have reduced ejection fraction, and they have loss of cardiomyocytes. We're reasonably comfortable about what's going on in people with ejection fractions of 55 or greater. These patients probably have an inflammatory or infiltrative disorder. Inflammatory infiltrative disorder. Here's the problem. Between 35 and 55%, there are patients in that zone that have the pathophysiology of HFrEF. There are patients in that zone who have the pathophysiology of hePF. You cannot distinguish HFrEF from hePF in the zone between 35 and 55 by measuring ejection fraction.
Thank you. And then just in line with that, I have a question from Dr. Thomas Linde in Norway concerning the results of this Paragon trial and the subgroup analysis. Do you believe that we should expand the use of sakubitil valsartan to treat hePF with ejection fractions up to 50-55% based on that evidence?
It's not just based on that evidence. We have data with almost every single neurohormonal antagonist. We have data with beta blockers, mineralocorticoid receptor antagonists, neprilysin inhibitors, that people between 40 and 50% ejection fraction respond favorably, just like people with an ejection fraction of less than 40%. They respond favorably, but the effect size is smaller, and these drugs do not produce a mortality effect in that zone. That's very important. And the reason is that zone is a hybrid zone. Some of the patients in that zone have HFrEF. Some of the patients in that zone have hePF. We are not able right now to reliably distinguish the biology of HFrEF and hePF in that zone. So if you want to give patients the benefit of the doubt, you can treat them with neurohormonal antagonists. It's not just a neprilysin inhibitor, beta blocker, mineralocorticoid receptor antagonist, but that zone is an opportunity for some people. But there are clearly patients in that zone who have an infiltrative and inflammatory disorder, and they will not respond to treatment with neurohormonal antagonists.
Yeah. So in that line of reasoning, I know that you have been writing about the inflammation and hePF and the potential role of epicardial fat and apidronexin. Yes. Could you expand a little bit on that?
So we have a reasonably, one thing which is really interesting about hePF is that there is destruction or dysfunction of cardiomyocytes, but without dilatation. This is really important because if you get loss of systolic function, but you don't dilate, then your ejection fraction does not go down, because your ejection fraction goes down only if your ventricle and if your end diastolic volume rises. So there are disorders that cause systolic dysfunction, but not left ventricular dilatation. Those are disorders that are hePF. Those are infiltrative disorders. I think for many people, it's an inflammatory state. And this inflammatory state is particularly common in women. And the inflammatory biomarker profile of these drugs is strikingly activated. There are many comorbidities in these patients, but these comorbidities are also the reflection of the inflammatory state, and some of them drive the inflammatory state. So the morbidities that really drive inflammation in HFpEF are obesity, chronic kidney disease, diabetes. These are really important drivers of inflammation. And so I would really encourage people to think of HFpEF primarily for many people as an inflammatory disorder. Many cardiologists think that HFpEF is the result of long-standing hypertension. And I do not think that's true. I think HFpEF in many individuals, particularly in women, is an inflammatory state.
Thank you very much. And that opens up, of course, for future therapies, but we won't have time for that right now. We'll go over to you, Filippo, on other questions.
Milton, you are a cardiologist with many talents. You are a top scientist. You are the most brilliant speaker, as shown today. You might well become president of the United States with your talent. But another talent is that you've been the PI, the principal investigator of many seminal trials. And you know, our readers do not know so much about what happens behind the scenes with trials. For instance, what is the role of a PI in a trial?
So I've been the overall PI of maybe almost about 20 trials or more now. So this is really important. In almost all cases, a sponsor has come to me and said, would you be interested in being the principal investigator of a trial? And you might ask, why do they ask me to do that? Sponsors are interested in developing products. They're interested in innovation, but they're also interested in getting a good answer to whether their drug works or doesn't work. And so sponsors go to principal investigators because they want the best possible trial. And when I'm approached by a sponsor, I give them the following answer. If you want me to do this, then I need to be able to do the best trial possible, because I am staking my integrity and my reputation on being able to deliver an answer to a question. People talk about successful trials, failed trials. I will give you my own personal definition of a failure in a trial. A failed trial is one that did not answer the question it was designed to answer. A failed trial is when one gets an answer that one does not like, and then one tries to change it. The goal is do the best trial, do it with integrity, do it so that you have an answer to the question. Whether the drug works or not may represent the truth. Your job is to deliver the truth. And so the relationship between the principal investigator and a sponsor is codependent. It is the sponsor needs the academic team in order to use their experience and integrity to deliver the best possible trial. And frankly speaking, the academic leadership desperately needs the sponsor because we have no money. We do not have a checkbook. The sponsor is paying for the trial. And so this is a partnership, and the partnership works when each side understands that it has a unique role to play. And when working together, you can deliver a trial that really answers a question.
Milton, a delicate ethical question along this line. What is the meaning of the word independence in this setting? Independence between investigator and sponsor. As editor-in-chief, of course, I'm very much interested in this question.
So the independence means that investigators can say what they want to say, full stop. They can say what the evidence shows. They can speak freely. They can speak without bias. And sponsors know that this is really critical to the investigative team. So if you are going to have a discussion with a sponsor on an ongoing basis about independence, then you are in a relationship that is not working. A sponsor has to respect independence. If they don't respect independence, they will not have a trial which is worth showing people. It will not be a trial which is worth publishing. The academic team must know that they can say what they see from the data. Here's what's something really important. Sometimes, very uncommonly, there's a disagreement between the academic leadership and the sponsor. It doesn't really happen that often. But occasionally, we are put in a situation where we are not entirely comfortable with the feelings that the sponsor are expressing or the pressures that the sponsor would like to apply. We have no money. We have no checkbook. We cannot pay for the trial. But we can walk away. We can stand up in a room and say, you know, this isn't working anymore. And let's take a break. The sponsor should recognize that it is in the sponsor's interest for the investigators to do their job. And once in a while, we have to remind the sponsor that our job is to show what the data are, to give our interpretation of the data, and to put our reputation and our integrity on the line for any given trial. So Filippo, when I stand up in front of an audience and I present the results, I am personally responsible for the integrity of those data. And I take that responsibility very seriously.
Milton, thank you for your very wise and clear words. I think that our readers are very interested in what you are saying. What about heart failure? How all this is working with heart failure trials?
Well, the only trials, Filippo, the only trials I've ever done are heart failure trials. I must say I'm a little bit specialized. I know there are trialists that do, you know, they do ischemia trials, they do infarction trials, they do arrhythmia trials. I have lived a boring life. I've only done heart failure trials. It's the only thing I know. Now, I would argue that, you know, heart failure has gotten a little bit bigger. We now have hePF and heFref. So it's a little bit of a broader universe, but I don't really think of myself as a trialist. I think of myself as a heart failure specialist. Above everything, clinical trials is just one tool. As you know, I spend a lot of time thinking about mechanisms. I actually write basic science papers on mechanisms. and they're all related to heart failure. So I'm really married to one disease. And if I can answer questions in that disease in basic science, fantastic. If I can do it in bedside observations, wonderful. If I can do it in a large-scale clinical trial, fantastic. But it's only one disease.
Milton, I'm sure that our audience is enjoying this very interesting Socratic conversation. And Socrates believed that the dialogue is the way to reach the truth, and we are going towards the truth. I'm sure that Cecilia's got other questions for you. Please.
Yeah, I'm going to be a little bit practical with you, Milton. And that is how we put the evidence from the trials into guidelines so that doctors know what to do. And just to make that question a little bit practical, I have two questions from Dr. Omran in Germany and Dr. Guy Bazzi in Italy that concerns the left ventricular remodeling, extent of sakubitil valsartan, which was evidenced in the Evaluate Heart Failure trial presented last year. And that makes it a little bit difficult for us who have device patients. In which order should we do things now? Should we wait for the remodeling effects of ARNI before deciding on to give a patient a primary preventive ICD or disease-modifying treatment such as cardiac resynchronization therapy? What is your advice?
Well, let me suggest the following. The indications for cardiac resynchronization therapy are based on pathophysiology of the disease, which has a lot to do with mitral valve anatomy and physiology, and I don't think depends that much on remodeling. When you have left bundle branch block, you need to fix the physiology, and delaying 12 months until neurohormonal antagonists kick in doesn't make a lot of sense to me. It's an interesting question about ICDs, though. ICDs are sort of a little bit different. And ICDs are supposed to prevent sudden death, but here's the trick. There are two forms of sudden death in patients with heart failure. There's sudden death from ventricular arrhythmias. And then what a lot of people don't realize, and by the way, I have written about this in the European Heart Journal within the last year, is there's another form of sudden death. It accounts for half the sudden deaths. It is an acute mechanical failure. It's not an electrical event. On the electrocardiogram, you have electromechanical dissociation or asystole or bradyarrhythmias. These are sudden deaths that are prevented by neurohormonal antagonists. So the problem with trying to figure out what to do is that our list of effective drugs for heart failure grows. So the question that you have was about neprilysin inhibitor. Well, okay, let me see. We can wait and use a beta blocker. We can then add a mineralocorticoid receptor antagonist, a neprilysin inhibitor. How about an SGLT2 inhibitor? Should we wait for all of that before deciding whether to place an ICD? And the truth is that as we are preventing more and more mechanical sudden deaths, I think the role of ICDs will decline. But I don't want to choose. I want to give the patients the best possible opportunity. Here's the problem with waiting. If you wait, the question that has to be asked to the physician is, how long will it take for a physician to use 4 drugs that should be using for HFrEF? How long should that take to implement? In clinical practice, that can take 9 to 12 months to implement. I would propose a totally radical way of thinking about this. If I had HFrEF, if I was just given the diagnosis, I would want to be started on 4 drugs in 4 weeks.
And then when would you want the CRT if you had an indication?
If I had an indication for CRT, I would want to have it within the 4 weeks. at the end of 4 weeks, I want to be getting the best possible treatment. Neurohormonal antagonists do not prevent the utilization of CRTs. They may prevent the utilization of ICDs, but not CRTs.
Well, thanks, Milton. That is very clear. So taking a deep breath here because of what you said, and going back to judging the scientific evidence. Now we'll get a little bit theoretical here. What scientific evidence would you look on with some suspicion? What rings the bells of alarm for you?
Well, I've been an advocate of a different approach to evidence interpretation. The traditional way of looking at evidence is to look at the evidence in a single trial and to spend a lot of time worrying about p-values, whether the primary endpoint is achieved at a p-value. What's the magical p-value? Well, the magical p-value is 0.05. Well, there is no magical p-value. It certainly is not 0.05. And most importantly, one should never, ever, ever look and focus only on the evidence in one trial. One should look at the totality of evidence across available trials. And when you do that, p-values become less important. Patterns and magnitude of effect and consistency of effect across trials becomes much more important. And that's why I refer to totality of evidence. If people spend an incredible amount of energy and capital chasing a p-value of 0.05, I think that's pretty suspicious. Because if you give me any database, even for a drug that doesn't work, and you allow me to manipulate that database and look for subgroups in the search of this magical p-value of 0.05, I will give you a p-value of less than 0.05, but I will not give you the truth. I will give you an artificial result with a p-value of less than 0.05. But what physicians need is they need to know what the drug really does. And a p-value of 0.05 in a single trial, however it's achieved, is not the primary way of determining what the trial showed. So this is a rather challenging point of view. A lot of people say, oh, p-values are really important. Well, p-values are not a religion, and p-values are not a substitute for thinking.
So I think this is very convincing, and we've seen this with the homogeneous results of this SLG2 inhibitors with various drugs. So it's thank you for explaining totality of evidence. Coming to another question, and what do you see in your crystal balls as the next breakthroughs in heart failure? And then we have a question from Alexandria, Egypt, Dr. Risk, who asks for effective new drugs for acute heart failure in the near future. That has really been a challenge, hasn't it?
Oh my God, so many wonderful questions. We need we need more time, but that's okay. The challenge for heart failure in the future is hePF. That's the challenge. We have the biggest challenge in HFrEF is not really new drug development. The biggest challenge in HFrEF is implementation. We have incredible evidence in HFrEF, and yet a small fraction of patients with heart failure and reduced ejection fraction are getting appropriate treatment. That they're getting all the right drugs at the right dose. It's a tiny, tiny fraction. So we're really good at evidence generation. really terrible at implementation. So the challenge in HFrEF is implementation. The challenge in hePF is new drug development. That is the real challenge. But in order to do that, we have to recognize this is really this is an inflammatory or infiltrative state. We're beginning to develop drugs with that in mind. And this is the real next frontier in heart failure, because this is now becoming the most important and most common phenotype of heart failure.
Thank you. I know that we are running a little bit out of time here, and I know that Professor Crea would like to ask you some additional questions.
Well, as I said before, you have many talents. You know that, as I said before, that our dialogue derived from Socrates, but I know that we are very familiar with the other important dialogues. Can you tell us more?
So, Filippo, as you and I have talked about, I have one passion, one hobby, and that is I'm a book collector. But many people are book collectors. But my focus has been on a collection of seminal works in medicine and science that changed the way that people thought about the world. One book in my collection is an original copy of Galileo's description of his belief that the solar system followed a heliocentric model, that the sun was the center of the solar system and not the Earth. He published this in a book, by the way, it was in Italian, in 1632. It was actually published by a grant from the Catholic Church. But the Catholic Church really didn't like this work. They had paid for it, but they didn't like the results. And they said to everyone, and particularly to Galileo, listen, if you are going to suggest that the sun is the center of the solar system, you are forbidden to say this directly. You can only say this as a hypothesis, a theoretical, unproven concept. So Galileo was under enormous personal pressure because he knew what the truth was, but he was struggling with how does he tell people the truth? So he published a book in 1632 called The Dialogues. It's a famous book amongst book collectors. Its full name is The Dialogue Concerning the Two Chief World Systems. And Galileo was very, very smart. So he created in Dialogues a discussion between two philosophers. One who thought that the sun was the center, and the other was that the earth was the center. And he thought, well, when he did that, it would just be a theoretical discussion, and the church would not be upset with him. But his philosophers were not equal in their skills. He gave the philosopher who believed that the sun was the center really strong arguments. And he named the philosopher who believed the earth was the center, he gave him the name of Simplicico, which sort of revealed what his biases were about this. So in book collecting, when one says dialogues, there's one book that book collectors refer to as dialogues, and that's Galileo's work. Those are the dialogues. As you know, Socrates believed in dialogues, but Socrates never wrote anything. Plato wrote all of Socrates' work. Socrates was one of the most famous people that never wrote a paper.
So, Milton, thank you for these remarkable considerations. But think about what you said confirms what Socrates said, that dialogues represent a way to reach the truth. Galileo confirms that this is a way to reach the truth. Now, my question is about our journal. What are your suggestions for the future of EHJ Dialogues?
So if I were you, I would continue what you're doing. This is wonderful. This is such a great opportunity. But I would make one humble thought. Make it as risky as you can possibly make it. Do not do anything conventional. Do not give your readers what they expect. Give your readers more than they expect. Surprise them. Give them something that makes them say, oh my God, I never thought of it that way. That is what makes dialogue special. Make people think. Do not do things that are ordinary. Do things that are extraordinary.
Milton, thank you for your wise words. It's very challenging, but definitely I'll do my best to follow your brilliant suggestion. I don't know whether I will succeed, but definitely
you will succeed. No. You will succeed. No doubt. No doubt.
I'll do my best. And well, this concludes our dialogue today. And please be ready for the next dialogue. I'd like to take this opportunity to invite you to the next dialogue, which will be on November 26th, the last Thursday each month. Thank you, Milton. Thank you, Cecilia.
Thank you so much. Thank you so much, Cecilia. Thank you.
Bye-bye.
Bye-bye.